Dr. Zappala is a respiratory and sleep physician in public and private practice in Queensland. His respiratory specialty training was completed in Queensland and London at the Brampton Hospital, where his interest in interstitial lung disease began. Dr. Zappala founded the Interstitial Lung Disease Service at Royal Brisbane and Women's Hospital, and this was quickly followed by the Pulmonary Hypertension Service. And you can read the rest of Chris's esteemed experience on that. So with no further ado, I'll hand over to Chris. Thanks for coming today, Chris. Appreciate it.
Thank you. Good morning, ladies and gentlemen. Thank you so much. It's my pleasure to talk with you about IPF and pulmonary fibrosis this morning. And as we all know, this is a very significant condition when it's diagnosed. It's not common, thankfully. We need to differentiate in our minds IPF or pulmonary fibrosis of that type, which is where there's no underlying cause. It's not an inflammatory condition. And it was really for that purpose that anti-scarring treatment was developed. But remember that there are many different other types of pulmonary fibrosis related to a whole bunch of other different lung conditions. And they have a different profile, a different prognosis, and different treatment, which may include anti-scarring agents. So I think one of my big take-home messages for you is pulmonary fibrosis does not always equal IPF. And so it's really important that we nail down as clinicians what type of pulmonary fibrosis you have. And I just counsel you to be gentle with us sometimes because it's not always clear. And we have to accept sometimes a degree of ambiguity. And that usually resolves itself over time. And one of the things I always say to my patients is that, and that sometimes we may even shift our ground down the track based on how the patient responds and behaves clinically and responds to treatment. There is still sometimes a bit of a delay to treatment, which is unfortunate, and we're working on that obviously as a community with our GP colleagues as well and our radiology colleagues. And there always, I guess, will be some delay, but hopefully we'll get that down. There's risk factors. Remember, a risk factor is not a cause. A risk factor is something that associates with. And there's a bunch of risk factors, and these are some of them. Most of them are intuitively obvious. Pollution and environmental exposures cause a whole range of conditions, not just lung conditions, but obviously lung conditions, including pulmonary fibrosis. Cigarette smoking obviously can cause a range of things in the lungs, but you do see people with IPF overrepresented amongst smokers, and so on. Reflux is a slightly contentious one in the literature, but it's in my view, it's definitely relevant. I'm in the reflux is relevant camp, and I accept that that's a divisive issue, and as it should be, we need to keep working on that and come to a landing. But there's a whole bunch of risk factors that are associated with that obviously we can manage over time, and be healthier as a result. So what is, I guess, pulmonary fibrosis, IPF, if we just use that term clumsily and synonymously for a moment, is there is basically abnormal repair. So the usual thing that happens in your lung, if there's injury, and obviously the classic injury is infection, right? But it can be something else. You could breathe in something noxious, non-infectious noxious that is, and you get injury. And so you get an inflammatory response, which is the body's generic response to a problem, right? And then that fixes whatever it is, cleans it up, and then what normally would happen is the tissue would return to normal. It would go back to what it was before. And when you think about it, you actually, your skin is exposed to the environment, well, so is your airway. And you see that happening on your skin all the time, don't you? And you think nothing of it. You get a little mark, it becomes a bit red or something, and then it goes away. But that's actually happening in your lung all the time. So injury, repair, injury, repair. But unfortunately in IPF, there's defective repair, and it doesn't go back to normal, and there's scarring tissue laid down. So in that process of repair, it inappropriately triggers fibrotic pathways or scarring pathways, and you accumulate a little bit of scar tissue. And so each time there's injury, repair, you get a little bit of scarring, and that accumulates over time. And that's the process. If we look at it under a microscope on the left there, you can see a lovely, thin, spongy, easy to move, lots of surface area, normal lung. On the right, you can obviously see what is quite different. It's thickened. There's not as much lung tissue there, is there? There's not as much surface area. There's not as much space for the oxygen to go over into the bloodstream. Because when you think about it, the lung is a simple thing. It's got airways, blood vessels, and the bits of tissue in between. That's all the lung is. And when we talk about the interstitium or the parenchyma, it's the bits of tissue in between. And that's what we're looking at there. And when we talk about interstitial lung diseases, that's what we're talking about. So you've actually got an impairment ultimately of that loading of oxygen or that transfer of oxygen into the bloodstream. But then I'm sure you can appreciate that lung on the right is a bit stiffer because it's not as spongy, it's not as easy to move. So each time you go to take a breath, you've got to put a bit more work in. So breathlessness is a complex symptom and it doesn't relate exactly to lung function because you have to bring into play those mechanical factors of breathing. You know, what's the chest wall like? Are you a bit overweight? Sadly, some of my patients are. You're a bit unfit. All of that adds to breathlessness, not just lung function. And if you look at the lung just with the naked eye, what we saw microscopically there is what you see, what we call macroscopically. So CT scans revolutionised what's happened in our field, and this is a range of scans. And I put this up really just to make the point that there's different types of scarring, right? And not all of these are IPF, but just to underline what I was saying before, and also so you can see the beautiful images that the radiologists are able to give us these days, and what has actually allowed a definition, a tight definition of IPF and other things. Can you imagine, 30 years ago when you really only had chest X-ray, or 40 years ago, it was a different landscape, and defining these entities was extraordinarily difficult. And so the advances that we see were preceded by the leaps forward in radiology, which enabled greater definition of these entities. This is a busy slide. Please don't try to read anything. It's really just to make the point that I was saying before. On your left, it's to remind me more than for you guys to read. And I know that you know this, obviously if you've possibly got pulmonary fibrosis, then there's going to be a whole bunch of diagnostic tests that you go through. So brace yourself, but there's going to be a few, and they'll include obviously scans, possibly bronchoscopies, definitely blood tests, a detailed history, with all those exposures and so on. And then we'll try to put that bet together and on the balance of probability, come up with a diagnosis. And some of the common interstitial lung disease categories with fibrosis are depicted on the right of the screen, just to show you that when we're thinking about it, there are many different entities. So IPF is just one, but we've got to think about the others, and that has implications for treatment and for generally how we manage you. I think it's really, really, really important, particularly when we give someone a diagnosis of IPF, because we all know that the first thing that pretty much all of our patients have done is they've gone to Dr. Google and they've had a look at pulmonary fibrosis or IPF, and then they've frightened themselves silly with what they've read there. And so it's not uncommon, and I'm sure Tam has the same thing, it's not uncommon that I spend a significant portion of my initial consultations with patients in deconstructing that and creating a pathway forward, but definitely dealing with the anxiety and grief that goes with a significant diagnosis. And that's normal and to be expected, because this is for many people a life-limiting condition, and that needs to be addressed upfront. I don't think you can get around that, and my preference with that is to have direct and honest conversations with patients, and that allows them to plan appropriately, and that's the only way to do it. Because I've not met a patient yet who doesn't worry about their family and their loved ones and what's going to happen down the track. So I think at the outset we need to recognise as clinicians that patients are having these thoughts, and they're reading all sorts of things on the internet and getting all sorts of helpful but usually unsolicited advice from other people. And one of our jobs as clinicians is to try to create some certainty and a steadying influence on that to help point them in the right direction. And we can do that. So what are the symptoms? So most things in respiratory medicine are either breathlessness or cough, and this is no different. And there is unfortunately occasionally fatigue and weight loss and other symptoms as well. But these would be familiar with most patients. I just wanted to underline the fact that I do think in general we're doing better. So you read the average survival, right, of 3 to 4 years, but I genuinely think we're doing better than that. That's the untreated patient, remember? That's historical data, untreated patients. I do think we're doing better than that in this day and age, even in the relatively untreated patients, because we wrap a much better holistic clinical service around these patients than we did before. And it goes to some of these sorts of things. So it's making sure that the patients exercise. I can't stress to you enough how important exercise is at any stage of a respiratory illness. And we know, for example, that pulmonary rehabilitation still benefits people who are on 24/7 oxygen. It still benefits people who are on transplant waiting lists. It doesn't matter how knackered your lungs get, exercise still helps. Because it's not about changing your respiratory function. It's about all the peripheral aspects that happen in your muscles, the cardiac aspects, the bone and joint aspects, the mental health aspects that all improve with exercise. So something like that is really important. And of course, preventing infection, so which exercise does, vaccination and so on, and thinking more globally around weight, diet and so on. I think if you do those things well, I'm utterly convinced that the patients live longer. And it takes time, but you have to do that. And a good ILD doctor will spend time doing that with patients. In other words, prescribing an antifibrotic and moving on is not good enough. If we look at disease behaviour, so disease behaviour is everything in interstitial lung disease. Most patients will have periods of stability and then maybe a little slip and then stability and a little slip, or slow decline. It's pretty uncommon to get rapid decline. But that's something that we're trying to understand. So when we do your serial lung function, and most patients sort of do the usual eye roll when I tell them they have to do their full lung function test again, because we know it's hard. It is not easy doing full lung function. I can't speak for my colleagues, but I have done full lung function tests and I agree with you, it's not easy. But so thank you for doing it, because it is very, very helpful. But we're trying to understand your disease behaviour, and decision making does hang off it. Just to help, in terms of treatment, this is really just to make the point that so we've got a sense of disease behaviour, and now we're thinking across all of, speaking for myself, we're thinking across all of these domains as to how do we manage a patient. And you can see that medication at the top is just one of them. And if you've got a type of pulmonary scarring other than IPF, there may be additional treatments besides antifibrotics that you can have. Supportive and palliative care is definitely important, and I just want to say something really clearly about that. That is not care of the dying patient. Supportive and palliative care, by definition, is the support and care offered to someone who has a chronic illness that will be life-limiting, full stop. There is no definition of time, there is no definition in any other sense attached to that, and it is about supporting that patient to be as well as possible. And I think it's really important that we apply that definition and do it, because it will help patients, I think, access resources and expertise that will help them to maintain their independence. I've had patients hooked in with palliative care for several years, and I think it's been helpful. And thankfully, I've got a palliative care service, and I think we should shift to calling it supportive care, who are happy to do that. I think the notion of time, to be perfectly honest, was a nonsense introduced by public hospital departments who had to limit their workload. And that was a perversion that created an unfortunate perception, which we need to dispel. The other thing I'll just mention is the peer group and support groups. It's not for all patients, but it is for some, and the Lung Foundation has those available if that's of assistance. Okay, I did want to mention antifibrotic therapy. My view with patient talks when I've done them is I don't dumb down my talks for patients, and I like to give you some of the literature that we depend on. My strategy with antifibrotics, because as we know they halve the rate of decline, is to get my patients on either full dose of either of the two drugs available, nintedanib, Ofev or pirfenidone, and if they can't tolerate that, then a lesser dose of whichever is the most tolerable. And I'd estimate that probably about 80% of my patients are on some degree, some dose of antifibrotics, so about 20%, which is consistent with the literature, can't tolerate. This is the original trials of Ofev and nintedanib published in 2014, and this was, I can't tell you how much of a revelation this was as an interstitial lung disease doctor, because we had really nothing before this. And this was published in the New England in 2014, and it showed that beautiful halving of the rate of decline. And you can see how nintedanib or Ofev works, is it knocks out a bunch of the scarring pathways, not all of them, but some of them. And this is in an IPF only cohort, and to show you that it works in non-IPF, this was a trial done in specifically non-IPF patients who had pulmonary fibrosis. So just to reassure you that that work's been done, and there's a whole range of diagnoses here, but the result was essentially the same, a halving of the rate of decline. So that's where the indications came from for our current listing. Pirfenidone, a complex molecule as well, and again, it knocks off a bunch of those pathways, not all of them, that promote scarring or what we call fibrosis in the tissues. And this was the original article in 2014, published within about 2 months of the original one, again in the New England. So we had nothing, and then within 2 months we had 2 drugs, well, there were 2 drugs in the literature. It took, as everyone knows, it took a couple more years for them to become available in Australia, unfortunately, but 2 drugs in the literature. And that was 2014, and as you know, we still don't have any other drugs. And that's not for lack of trying, but hopefully there are some on the horizon, which Tam has alluded to. This is to show you, because I think efficacy is important, this is to show you when we look at what we call as a meta-analysis, so when we bunch together a whole heap of studies and pool all of the patients together, and make one great big data set to give you a more powerful result, we can show that there's a very clear benefit in mortality. So patients on antifibrotics live longer, full stop. The other question that I get asked quite a lot is, so as we know, even on treatment, unfortunately, patients are still going to decline. So a patient of mine, they might have a little slip down and they'll feel that, right? They'll come in and they'll go, listen, oh, my walk is just not quite as easy. I think I might have slipped a bit. And their next question is going to be, should I stop my antifibrotic? Has it stopped working? Should I, is there a problem there? And the answer to that is no, it's all fine. We know, unfortunately, that you will decline. And if we look at the data here, you can see Esbriet or pirfenidone. Even if you have a slip, if you remain on it, your chance of having another slip is much reduced again. Okay, so you don't have to change, is the point. So they keep working. That's not to say that you mightn't decide to change for another reason, but you don't have to change. They do keep working. Side effects, unfortunately, as we all know, the side effects are the bane of our existence, and it'd be nice if we had cleaner drugs. This is pirfenidone. Gastrointestinal, this is real world data, not from the original trials that I showed you. And the difference with the original trials is that gastrointestinal side effects are probably a little bit more frequent, and rash is probably a little less frequent in this data. In my practice, rash is probably a bit more than 7%. It probably is a bit closer to the 15 to 20% like in the original trials. But the stoppage rate of 20%, as I say, is about right, what you see up there in terms of consequence. So gut and skin are the main ones for pirfenidone, and they're common. I think the other problem with pirfenidone is you have to remember to take that midday dose. And I got a lot of patients that forget that. And we put in strategies to try to... It's really hard to get a dosage box for one dose, isn't it? I've discovered. But that's what they need, to slip into their pocket so that they can go about their day and then remember at lunchtime. Yep, understood. So I'm nearly done. And so this is nintedanib, similar scenario. With mainly gastrointestinal. And I wanted to show you this. This is real world data showing that drugs work. But what was really interesting here, they said to the patients, how do you feel about these side effects? And they very strongly said, if this medication is working, I'm happy to cop the mild side effects. And that's something that I definitely hear in my practice as well, and that's come through very strongly in the literature. The reason antifibrotics don't work completely is because the pathways to fibrosis, as you can see there on the right, are many and varied, and we're only blocking some of them. So we do need better drugs, and they're on the way. This is just to make the point that I've spoken mainly about IPF, but as I mentioned, there are other types of pulmonary fibrosis. And if you've got one of those, there are other treatments that might be available. And this is from the recent guidelines of scleroderma interstitial lung disease, which show that there are many other options as well as antifibrotic therapy that we can use. I'll just finish by saying there's a few things, again, to make the point that it's not just about drugs. If you're a smoker, then we need to help you with that, obviously. With your oxygen, oxygen is an enabler. For a lot of patients, they say, I want to put that off, that's a failure if I need to do that, I don't want to become dependent, etc., etc. I understand that, but that's the wrong way of looking at it. Oxygen's an enabler. It helps you manage breathlessness, keeps you active, it helps with your mental acuity, and so on. And so that's a discussion I think you should have with your doctor about when to use that if it's required, and then which portable one you get is very much a personal choice. Weight I've referred to, can't be too heavy, can't be too light. It's important to manage the lifestyle factors. And I did want to just finish with exercise because it's so important that we do exercise. Anne Holland, the current president of the Thoracic Society in Australia and New Zealand, has published extensively on this topic in interstitial lung diseases and shown that you don't have to do continuous training, you can do interval training. So exercise, rest, exercise, rest, exercise, rest, and that is just as good. And symptoms I'll leave to Natasha Smallwood to talk to. These are some of the places you can go to get your peer group support. The Lung Foundation, as I mentioned, has a peer group support for you as well. And just to finish on, I wanted just to give you a sense. Yes, there's been a bunch of negative trials, and I've listed them there, but don't worry, there's also been a bunch of positive trials. And those are the ones that I've listed on the right side, and there is further work ongoing. Thank you.
Great. Thank you very much, Chris. It can be challenging to digest that very complex sort of work, but thank you. And I think that strong message that lifestyle exercise is also an important aspect of the things that you can do to improve your sense of well-being. So we want to open up the question time for you. For those online, there is a Q&A that you can submit those questions online, and we will also look at those and present them to Chris. Just as a reminder, this is not an alternative to you and the medical advice that you get from your healthcare team. So appreciate that the questions are general ones. But if anyone has a question, we've got a roving microphone that we can take to you. So does anybody want to break the ice and make a start? Yeah. So we'll just get Alison.
So I had a fibrosis for 2018 and before. I'm still alive, we are still without any medication. I'm very positive, I would travel, I don't know what. Okay.
That's wonderful.
So somebody can live more than 5 years, believe in me.
Yes.
If you don't keep in, it's okay, be positive.
Yeah.
Okay, that's it.
Sorry, this one on? Sorry. Yeah, Chris, we've had a question online. What would you say is the best treatment for gastro symptoms as one of the side effects?
Yeah, look, that's tricky. So first of all, the basics are important. You're going to make sure you're taking the medication with food, and sometimes the particular timing with food can make a difference. And a low fibre diet can definitely help some patients. I'm not sure about in the other states, but in Queensland, I just Googled Queensland Health low fibre diet, and the first thing that comes up in the Google search is a really good low fibre diet that Queensland Health has, which I print out and give to patients. And then beyond that, it's you can use the occasional dose of Gastrostop or loperamide. And so I've got patients who use that as required. I've got patients who use it routinely. So they might take one every morning and occasionally use an additional dose. as people would know who are on nintedanib, it's often the case that you have sort of a couple of good days and then for no good reason just a bad day. And so I think you just have to be prepared for that and maybe take extra loperamide on those days. That really, I think, is all the things that work in the main to manage that. Of course, there are dose changes, but then you're going to be potentially changing the efficacy of the medication. And if the side effect becomes too difficult, remember, and if you've not tried pirfenidone, you could try pirfenidone as an alternative, and you might tolerate that better. And remember, fortunately, in our system, if something happens, you can still go back to the nintedanib. So there's nothing to stop you from doing that. So if you haven't tried pirfenidone, because you might be perfect on that, then that's an alternative. So I just would discuss all of that with your doctor. I think diet is relevant, but that's such a variable thing, and I always hesitate to get people to change their diet too much, but that clearly is relevant.
Thanks, Chris. And we've got a question. Yep.
Fibrosis is a sort of natural body mechanism to deal with damage. Your medications are blocking some of the pathways. What sort of off-target effects does that produce in other damage elsewhere in the body?
Well, I'm not sure that it's natural in the sense that it's the routine way of dealing with damage, because we always want a restoration of normal function. So normally we wouldn't have fibrotic pathways put in place. So we're actually trying to avoid those where possible. But your question is reasonable, and I think the most obvious manifestation of that is that there is a potential delaying time for wound healing and so on, because obviously some of those pathways cross over because they have an effect in that space, so they have an effect in wound healing. And so the consequence really is for, I guess, major surgery, those sorts of things, whether you cease the drug temporarily so that you don't inhibit wound healing. I don't think it has an issue in terms of the infection risk, it's just that time to wound healing. So I've got a patient recently who I want to start on drug. I saw her last week, but she's about to have coronary artery bypass grafting literally in about 2 to 3 weeks' time, and we agreed that we would just hold off for a couple of months and then start the drug just so that we didn't have that effect. That doesn't mean that you have to stop it. I think if you're going to have major surgery, I think that's a discussion that you have with your prescribing physician. But I think that would be the consequence that you're talking about. Yeah.
Thanks, Chris. We've just got our last question with the gentleman in the front.
Chris, how long do you think would be until the delivery system of the current drugs is approved in Australia?
What do you mean a delivery system, sorry?
Well, a nebuliser instead of a tablet.
I can't see that happening. Why do you want a nebuliser?
To avoid some of the side effects.
Oh, I see where you're getting at. Yeah, that's a good thought, but I'm not aware of that formulation being looked at, unfortunately. I mean, remember that the commercialness drives a lot of things, not inappropriately to some degree. Nintedanib comes off patent next year, so the generics will flow into the market. So the want to develop new things, I think, is going to probably, with that same drug, is going to diminish. And that drug company, for example, has got a new molecule. The phase 3 trials are about to finish, and if it's positive, then it will represent a new class of drug, and they'll obviously be pouring their resources into that, not finessing an old molecule that's off patent that they're not going to, do you know what I mean, make any money from, which is not necessarily a bad thing because the new molecule might be better. So let's wait and see what that happens. But in answer to your question, I like the way you're thinking, but I don't think it's going to happen, unfortunately.
Thank you, Chris. And thank you. We'll wrap up that session with Chris now. Thank you. A small token of our thanks for taking your time to chat to us all today. Thank you so much.